renal and metabolic diseases. So when we're talking about renal diseases, we got two different things we are looking at. We're looking primarily at either glomerular diseases or tubular diseases. So remember, the glomerulus is the piece up at the top, you know, in the Bowman's capsule. It's something going on in the sieve, in the colander part of the kidney. The other thing we look at then is the tubular diseases. So the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule. That would be the second component of the types of diseases. We're also going to talk about renal calculi or lithiasis. Lithiasis is the formation of stones. So, you know, when we're talking about kidney stones, that's what we're talking about there. So when we start talking about renal diseases, we're going to talk first about urinary tract infections. So when we're talking about urinary tract infections, we have the upper urinary tract infection or lower urinary tract infection. When we're dealing with the upper urinary tract infections, we're dealing with the pyelonephritis. We're dealing with the kidneys themselves, inflammation of the kidney and the renal pelvis. That's pyelonephritis. When we're talking lower urinary tract infection, we're talking cystitis and urethritis. So infections of the bladder or the urethral. So depending on what we're looking at when we're looking at infections, we're either looking at upper or lower. Other renal diseases include things like renal failure, which a urinary tract infection can eventually lead to failure issues. We'll talk more about that in an upcoming slide. So we're going to talk first about glomerular disease. So most of the time when we're dealing with a glomerular disease, it's something immunologically mediated. We have this antigen antibody reaction, and they're going to form complexes and precipitate that's going to end up damaging the glomerulus. So it actually hits the glomerulus and damages the glomerulus. As the disease progresses, we're going to end up getting some renal tubular involvement also. And then it's going to lead to glomerulonephritis. So glomerulonephritis is actually just inflammation of the glomerulus. It can be in many forms, but its primary characterization is we get blood and protein and casts in the urine. So glomerulonephritis, we get this inflammation of the glomerulus, the colander or the sieve, the holes get bigger and larger things, larger molecular weight things start getting through the glomerulus into the glomerular filtrate, which is going to end up in the urine. So a couple of characteristics of glomerulonephritis. Oftentimes it's caused by an infection or underlying disease state, and you get this antibody to a bacteria, and sometimes it's an antibody to self, so it's an autoantibody. Some cases are considered idiopathic, and what that means is they really don't know what the cause is, but you end up getting inflammation of the glomerulus. Most of the time, if you think back to your immunology courses, we talked about glomerulonephritis being post-streptococcal. So you get a strep infection, the antigen antibody create complexes. The complexes then deposit on the glomerular membrane and starts causing that damage. Like I said, you get the holes in your colander. When that starts happening, anytime you get any sort of damage in the body, you start getting an inflammatory response. So those inflammatory cells are going to start migrating to the area, and the glomerulus becomes really large and very cellular. So here's a picture of a normal glomerulus, a drawing and a picture, and you can see it's kind of like puffy and cotton candy, and versus these guys. So the normal one is on the left, and on the right you can see glomerulonephritis. So the glomerulus becomes enlarged, increased cellularity. You can see how many more cells, how much more packed and how much more dense those glomeruluses actually are in glomerulonephritis. So when we get glomerulonephritis, we're going to see a decrease in glomerular filtration and oliguria. Remember, oliguria is like reduction in urine, so urine output. So you're not going to be urinating as much. You're going to get elevated blood urea nitrogen and creatinine because when you start getting that inflammation, some of these particles aren't getting through the glomerulus into the glomerular filtrate. So the stuff's not going to end up in the urine. Remember, those are byproducts of muscle metabolism and breakdown. So it doesn't get into the urine because the glomerulus is so swollen it can't get through. You're going to end up with sodium and water retention, and when you get that, you're going to end up with edema throughout the body. And then in the urine itself, the chemical exam, you're going to have positive protein in blood, and you're going to have a low specific gravity. It's going to be less than 1.010. And you're oftentimes in the microscopic then going to see red cells. You're going to see the dysmorphic red cells. And if you remember from the reading a couple lectures ago, the holes in your colander get big, and the red cells, because they're under pressure, the holes are big enough now for them to push those red cells through. And remember, the classic red cells become those Mickey Mouse red cells, but they become dysmorphic, misshapen, because they get squeezed through that glomerulus. We're also going to see on microscopic exam white cells, renal tubular epithelial cells, and we're going to see casts. And we're going to see red cell casts, hemoglobin casts, granular, and sometimes some white cell casts, and sometimes some renal cell casts. And so the farther along the glomerulonephritis goes, the worse it gets, the worse the cast formation are going to be. So there's different types of glomerulonephritis. Acute glomerulonephritis is going to be like a rapid onset. Anytime you see the word acute, it's sudden, rapid onset, early stage disease. Oftentimes, this is what we see in children and adults following group A strep infections. We see this acute glomerulonephritis. Other bacterial infections can cause it also through the same mechanism. The second one we're looking at is rapidly progressive glomerulonephritis. So this can occur also following an infection, but oftentimes it's secondary to other systemic diseases like lupus or vasculitis, or idiopathically, so following a flu-like illness, meaning you get sick, we really don't know what caused it, you end up with like a flu-like illness, and now it's going to lead to a rapidly progressive glomerulonephritis. Sometimes it may represent the fulminant and rapidly progressive phase that occurs in some cases of acute. And what fulminant means is kind of like end stage big disease. When you see fulminant, it's kind of like, whoa, everything's big, everything's problematic now. Membranous glomerulonephritis is characterized by thickening of the glomerular capillaries. This is often secondary to things such as lupus, diabetes, thyroiditis, or following those heavy metals. And I remember we've talked several times, heavy metals being really, really bad for the glomerulus. So that's what we're seeing in this situation. Oftentimes, this membranous glomerulonephritis can transition to nephrotic syndrome more suddenly and more often than other forms of glomerulonephritis. Chronic glomerulonephritis develops as a result of prolonged glomerular inflammation. So you can get this because of renal disease or systemic disease or idiopathic cause also. But when you start getting this glomerular inflammation that just hangs out, it keeps going and going and going, you can end up with chronic glomerulonephritis. Oftentimes this progresses pretty slow. You can actually watch it and follow trends of your lab results over time. But you do end up with glomerular scarring, and eventually the nephrons, you're going to end up losing functionality of them, and you're going to end up with dialysis or possibly even transplant as the disease progresses. Nephrotic syndrome. Nephrotic syndrome we use to describe a whole group of clinical features. Remember what I talked about before a couple lectures ago. Anytime you see nephrotic syndrome, you should think fat. Anytime you see fat in the urine, you should think nephrotic syndrome. Oftentimes you see this at the end stage of glomerulonephritis, but it can also occur secondary to infections such as syphilis, circulatory system defects, allergic reactions, toxins, and other disease states such as cancers and lupus. The characteristic urine findings for nephrotic syndrome is going to be increased protein greater than 3.5 grams per day, largely albumin. So this is one of those tests. They're going to end up doing a urine. It's going to be positive for protein. They're going to do a 24-hour urine and see, wow, really positive for protein. Again, nephrotic syndrome, we're going to see lipiduria. We're going to see oval fat bodies, free fat droplets, fatty casts, fat. Nephrotic syndrome, fat. Keep those solid in your brain. You're going to start seeing casts, including renal tubular epithelial and waxy and fatty casts. Remember, waxy casts, that's like end stage of the casts. We're not getting any urine, urine is stasis. We're not getting urine flow, and because of that, we're not flushing those casts out, and they're drying out and getting icky. We're also going to see hematuria. Other hallmarks we're going to see, not necessarily related to the kidney, or not necessarily related to urine, we're going to see decreased serum albumin. And the reason we see the decreased serum albumin is because the albumin is leaking out through the kidney. Remember, that sieve, that colander should not be big enough. The molecular weight of a healthy glomerulus, things 60,000 molecular weight or less can get through. Albumin is at 67. So because we've got such holes in our glomerulus and we start seeing such problem, all the serum albumin is seeping through is seeping through into the glomerular filtrate and getting out in the urine. So the actual serum albumin is low. We see increased serum lipids, hyperlipidemia. We don't really fully understand the reason for this, but we see not only lipids in the urine, but increased lipids in the serum. And then generalized edema. So because of decreased excretion of sodium and alterations of that osmotic pressure of the blood in response to the protein loss, we're going to have generalized edema in the body. So during nephrotic syndrome, here's some pictures of what's going on. You get this damaged glomerular filtrate, allows the protein to leak in the urine. Because there's less protein in the blood, water is going to move out of the blood into the surrounding tissues, causing edema, and you're going to end up with proteinuria. So protein in the urine and edema in the body. And you can see the picture there on the right. That's edema of the feet and the legs. We have pitting edema, and so the nurses will actually get into this, but when you push on it and it stays dented, so if I push my finger on it and it stays dented, that's called pitting edema. And when we get pitting edema, they can determine how bad it is and grade it based on how long it takes for that to kind of go back to normal. So now we're going to look at some tubular diseases. We're going to look at acute tubular necrosis, characterized by destruction of the renal tubular epithelial cells, and therefore, when we lose those renal tubular cells, or we destroy those cells, we lose tubular function. This can be due to ischemic episodes, so small parts of the nephrons having stroke-like, they don't get the blood flow, so they're just going to die off, or exposure to nephrotoxic agents. Drugs, toxins, and heme pigments. Remember we talked acute intravascular hemolytic episodes. Those heme pigments are going to go into the bloodstream, and heme is toxic. Hemoglobin and myoglobin both are toxic to the kidneys, so it can cause kidney function to severely drop with these episodes. When we look in the urine, we'll often see renal tubular cell fragments and a variety of casts, granular, tubular, cellular, and waxy and broad casts. So remember, broad casts are the worst because that means that the wider areas in the tubules, we have stasis enough where we're letting the jello solidify in that extra piece. Renal tubular acidosis is characterized by the inability of the kidneys to produce acidic urine. So because what happens in that distal convoluted tubule, remember that's where most of that acid-base balance is going to occur to keep the blood pH at that nice tight range of 7.35 to 7.45. But the distal convoluted tubule, the inability to secrete hydrogen ions, inability to increase tubular ammonia secretion to compensate, the proximal tubular reabsorption of bicarbonate is inhibited, and the impaired ability to exchange the sodium for potassium and hydrogen in that distal tubule. So because of the acidosis, we're going to get the inability of the kidneys to produce the acidic urine because of all of this. Cystinuria, we're going to talk here about cystinuria and cystinosis. It's important that you understand the differences. When we're looking at cystinuria, it is an inherited disorder just like cystinosis is, but in cystinuria, the renal tubulars are unable to reabsorb the amino acids cysteine, ornithine, lysine, and arginine. Because of that, those amino acids are excreted in the urine. The issue is, however, cysteine readily precipitates and will form crystals in concentrated urine with an acid pH. Those crystals can eventually form into stones and cause severe kidney damage on their way out. Treatment for this, main treatment is remain well hydrated. Hydration is important for so many things, but this is going to be one of them. Particularly during the night, because the urine becomes concentrated and acidic at night. So it's really important to drink a lot of fluids before bed, and if you wake up during the night, to drink. We can also give medications that convert the cysteine to a soluble form, which will hopefully help prevent some crystal formation and some stone formation. Now, cystinosis versus cystinuria, it's also inherited, but in cystinosis, the cysteine cannot be properly metabolized. The body cannot break it down. And because of that, the cysteine is going to accumulate in organs and tissues, including the kidneys, the eyes, the bone marrow, and the spleen. It can cause a large variety of symptoms, including opacities in the cornea. It can cause rickets. It can cause growth retardation. And the crystal accumulation in the proximal renal tubules can cause extensive renal damage and lead to Fanconi's syndrome. So cystinosis and Fanconi's syndrome are another of those two words that you're going to see back and forth. If you have one, most often cause of Fanconi's syndrome is going to be cystinosis. Without dialysis, these patients with cystinosis are often going to die by the age of 10 just due to their renal damage. So here are some crystals in urine for cysteine. Cysteine crystals tend to be plates that grow on top of each other, so they tend to be a little more two-dimensional versus like a calcium oxalate. When you look at a calcium oxalate in a urine as you're playing with your focus, you can actually see it's three-dimensional. These are more plates that develop on top of each other. And then in this other picture, you can see some cysteine stones, how big they can get. And you can just imagine the amount of damage that's going to do to the kidneys. Fanconi's syndrome is a general term used to describe the condition and characterized by general loss of proximal tubular function. Results in amino acids, glucose, water, phosphorus, potassium, and calcium all being lost in the urine because they cannot be reabsorbed. So remember that proximal convoluted tubule, all that stuff comes through the glomerulus into that glomerular filtrate, but the body's like, just kidding, we want all that back. And so the body's able to use in that proximal convoluted tubule to reabsorb all these things back. But when you lose function of that proximal tubule, all of those things get lost into the urine. The most common cause of this will be the cystinosis. Remember, cystinosis, Fanconi syndrome. Put those two in your brain together. Also, it is associated with some other inherited diseases, toxic exposures, metabolic bone diseases, and renal diseases. But most of the time, the most common cause of Fanconi syndrome will be cystinosis. Renal calculi or kidney stones, solid aggregates of chemicals, usually mineral salts. So stone composition, about 80% of all kidney stones contain calcium. 10 to 20% of them are composed of triple phosphates. About 10% are made of uric acid. Uric acid stones are more common in men and oftentimes associated with gout or chemotherapy. About 5% of women and 10% of men will have at least one episode of kidney stones by the age of 70. And a person who has had a kidney stones often is going to get them again in the future. So you get one bout, you're likely to have them more often. Lithiasis is stone formation in an internal organ. So nephrolysis, renal lithiasis, and nephrocalcinosis, all some different terms formed for this, but renal calculi, lithiasis can be stone formation in any organ, and like think gallbladder and gallstones, but we're really looking at renal stones in this situation. So factors that contribute to stone formation: reduced urine flow, related to decreased intake. So hydrate. Hydration is so important. Increased concentration of salts, and stone formation occurs when a pH is constant. So think about when we make crystals here together. We had an acid. I used acid because I used vinegar, but you can also do ammonia, do a basis crystals. We'll make an acidic environment, increase chemical salts, give it a place to form. And the small little crystals, as we watch these crystals grow, they're going to start as tiny little crystals, and then they're going to grow into larger and larger crystals and stones. So renal calculi oftentimes are going to cause hematuria because these stones are big and they're going to scrape the internal parts of the kidneys as they move through the kidney and going to create bleeding. So we're going to actually get blood in the urine. The presence of crystals in a freshly voided urine may suggest that conditions are right for stone formation, but not because you have crystals does not mean you're going to necessarily get stones. It indicates the conditions are right, but it is not necessarily an indicator that you will end up with stones. So urinary tract infections, again, we talked about this earlier in this lecture. We're going to talk about it a little bit more now. Upper urinary tract infections, pyelonephritis, that's going to be your kidney infection, versus your lower urinary tract infections, which is your cystitis and your urethritis. Cystitis is a bladder infection, urethritis infection of the urethra. So cystitis and urethritis, when we get these, we're going to have pain and burning on urination and dysuria, which is uncomfortable urination. Occasionally, you're going to have some abdominal pain, but not often. It's not a real common, lower urinary tract infections do not commonly have abdominal pain. When we do urinalysis, we're going to see a lot of leukocytes, mostly neutrophils, moderate to many bacteria. Minimal hematuria and proteinuria may be present. So you may see that, but there's not going to be necessarily a lot of red cells and protein. Increased number of transitional epithelial cells, because remember the transitional ones are from that lower UTI or urinary tract infection from the bladder, things like that. So we're likely to see increased number of transitional epis. Definitive diagnosis of a UTI requires a bacterial culture. So if you get this in the lab and you see, oh, lots of white cells, lots of bacteria, not many squamous epis, because remember, squamous epis is a sign of contamination more so, garbage in, garbage out. We're going to send this over to the lab. And a finding of 10 to the 5th colonies per mil indicates infection. That's supposed to be not 105 colonies, that's 10 to the 5th colonies per mil. Acute pyelonephritis, bacterial infection involving the renal tubules, interstitium, and renal pelvis. There's 2 different ways bacteria is going to gain access to the kidneys. We got moving from the lower urinary tract to the kidneys. That's the ascending route. And then the descending route, migrating from the blood into the kidneys. Ascending is way more common than descending. If we end up with a descending, chances are really good you've already been sick, because if you've got sepsis, if you've got bacteria in your bloodstream that's heading to your kidneys, you're already probably sick. And that's going to be more of a issue with people that are hospitalized. Most people get it. It kind of goes as a urethritis to a cystitis up into the kidney. Sudden onset is characterized by flank pain. Remember the back, where the kidneys are in the back, that's your flank. Painful urination and frequent and urgent urination, but oftentimes there's not much there. It's like, oh, I gotta go. And you go to the bathroom and it's just this little bit of urine there. It's not much, but it's gonna feel like you've gotta go frequently and urgently. Without antibiotics, it's usually self-limiting and will last 1 to 2 weeks. Often is going to cause no long-term problems. However, it's a miserable disease. So antibiotics, with antibiotics, you're talking only a couple days and your symptoms are going to start disappearing. With acute pyelonephritis, your microscopic urinalysis, you're going to have bacteria, many leukocytes, few to moderate red cells. The differentiate between acute pyelonephritis from cystitis is you're going to see casts and proteinuria. When you see the casts and the proteinuria, that's what's really going to differentiate the two. Chronic pyelonephritis is due to recurrent urinary tract infections or an obstruction that allows bacteria to remain in the kidneys for long periods of time. When you get chronic pyelonephritis, you're going to have scarring of the renal tissues and loss of renal function. And the urinalysis is going to have increased leukocytes, proteinuria. Bacteria may or may not be present. It kind of comes and goes when you get this chronic pyelonephritis. But you will start seeing casts early in the course of a disease. But then later, they're going to be more absent in the more chronic stages. In chronic pyelonephritis, it's going to be inability to concentrate urine as tubular function starts becoming lost. And you're going to get polyuria and low specific gravity. Renal blood flow and glomerular filtration gets affected in the late stages, and about 10 to 15% of patients develop chronic renal failure and are going to require dialysis. Brings us to renal failure, acute renal failure, a sudden sharp decline in renal function. Oftentimes this happens in hospitalized patients due to some other process going on. Something's going on, you get acute tubular necrosis, which is going to cause acute renal failure. Now, chronic renal failure is a gradual decline in renal function over time. It occurs often as a complication of other diseases, such as chronic glomerulonephritis. So again, this is one of those that are going to watch renal function decline over time. Now, metabolic diseases are a common cause of renal issues when we're dealing with renal diseases. So metabolic issues are incomplete or defective metabolism of substances resulting in accumulation in the blood of unmetabolized substances or intermediate products of metabolism. So what happens is products can accumulate in other organs and cause long-lasting detrimental effects, such as mental retardation and central nervous system degeneration. So it's really critical that we get early detection of these diseases. Some of the ones, diabetes mellitus, we've talked about that. Galactosemia, we've talked about that one. We look for it in enzyme deficiencies. Cystinosis, enzyme deficiency to break down your cysteine. Porphyria, maple syrup urine disease, phenylketonuria, and alkaponiuria. So we're going to primarily here talk about those last three. Maple syrup urine disease, it's an inherited metabolic disease. And what happens is we lack an enzyme needed to metabolize those branched chain amino acids, leucine, isoleucine, and valine. So because of that, these amino acids, because they can't be broken down, they get accumulated in organisms, causing severe symptoms, characterized by acidosis, central nervous system disease symptoms, and urine that smells like sweet maple syrup. Oftentimes, we diagnose this through the newborn screen, but oftentimes the nurses in the neonatal ICUs and in the nurseries are going to note this, these failure to thrive babies. These babies are going to like be real, they're not going to feed well, they're going to be lethargic. They're going to note that the urine smells like maple syrup before the test results even come back oftentimes. Sometimes you can have death even occur within these first few days of life. So it's really important that these nurses recognize this. So this picture is going to show you pretty much, this is maple syrup urine disease. However, all of these metabolic disorders like this are going to be very similar. For the maple syrup urine disease, you do not have to memorize this, but the BCAD enzymes, the branched chain amino acids, the enzymes are going to break them down, and they're going to have energy and growth. They're going to have those, the enzymes are going to allow for those to happen. When you have maple syrup urine disease or any of these deficiencies, you lack the enzymes you need to break down whatever it is that's causing the problem. And because of that, you're going to have lack of energy and lack of growth, the buildup of the amino acids, and it's going to lead to health problems. So again, newborn screening, we collect, do the newborn screening. Treatment for this, dietary restriction of the branched chain amino acids. So we want to limit their diets. So as soon as birth as we can, and all the way through childhood and adolescence, we're going to have to follow these dietary restrictions. You need to get the special infant formulas for treatment. You can't use breast milk. You can't use normal formulas. These formulas are super, super expensive, like up to $1,000 for a can of formula. The nice thing we do in Wisconsin, and I don't know what the numbers are anymore, but at one point it was $100 to get the newborn screen. $50 went to pay for the testing, and $50 went into a pool of money that would help cover these formulas for these babies that were born with these metabolic disorders. So they could afford the formula. Because you can imagine that an average family is not going to be able to afford some of these crazy formulas. Regular formula is expensive enough. This is high. Phenylketonuria, PKU, it's another inherited metabolic disorder. It's another enzyme lacking to break down and digest phenylalanine. Phenylalanine is in breast milk, cow's milk, soy milk, formulas. Symptoms at birth, there's no signs of the disease. There's no real signs that they have it, but within the first few weeks of life, they end up with these neurological disorders. Children suffering from undiagnosed PKU may have this like musty smell to them. And signs are going to include skeletal changes, and some of these kids may have eczema. In Wisconsin, newborn screening does pick up PKU. We want to maintain, when we're treating these people, however, they have to maintain a blood level of phenylalanine between 2 and 10 milligrams. So it's required to have some, but you don't want much more than 10 or you're going to start having problems. In order to do this, we have to avoid high protein foods. Most of these people live on a diet composed of cereal and starches and fruits and vegetables instead of actual proteins. Alkapoteinuria, it's another inherited metabolic disorder where they lack the enzyme to break down homogesic acid. Homogesic acid then gets excreted in the urine and the urine turns to like this brown or black color upon exposure to air. Urinalysis gets positive for reducing substances. If they do a clinic test, they'll be positive. The normal dipsticks, nothing will show, but if they do clinic test, it will be positive. But the homogesic acid can also accumulate in the body, and you can see here in the bone and cartilage, it can turn the ear cartilage there to that kind of like brown color. It can cause progressive arthritis. It can land on the heart valves. It can land in the sclera of the eye, and it kind of makes that weird blue or gray discoloration in the eye. So none of this is good for long term. Treatments, some patients benefit from high dose vitamin C. It's going to decrease some of the buildup of the brown pigment in the cartilage, which may slow the amount of arthritis. Outcome is usually pretty good for these patients if we get them treatment early. So we're going to talk about some renal function tests. We're going to talk about glomerular filtration tests, tubular reabsorption tests, and tubular secretion and renal blood flow tests. Glomerular filtration. Now, remember, we talked about this back in, I believe it was lecture 1 or 2. 180 liters of filtrate produced per day. So when we start having impaired glomerular filtration rate, metabolic wastes then are going to accumulate in the blood and cause problems. So it's really important for us to know that our glomerular filtration rate is pretty good. So we can do clearance tests. We perform these to detect the renal disease at an earlier stage, and it can measure the rate at which the kidneys are able to remove or clear a filterable substance. So when we do clearance tests, there's a few things we need. We need a substance. It must be easily filtered by the glomerulus. If it's not filtered by the glomerulus, it's not going to tell us if it's, what the glomerular rate is, the filtration rate is. We don't want it reabsorbed nor secreted by the tubules, and we don't want it created or destroyed by the body, because that can affect the, if it's being created by the body, the serum to clearance ratio is going to be kind of messed up. Other factors, we want it consistent in the plasma level. We have to have a test to test for it in the lab. And we want it stable over a 24-hour collection period in the urine. We don't want it breaking down once people urinate, because we have to do a 24-hour urine test for it. So there's a couple different ones we look at: the urea clearance test, which is obsolete, the inulin test, and the creatinine clearance test. So the inulin test is the reference method for determining this. Inulin is non-toxic, it's not produced or destroyed, it readily passes the glomerular filtration barrier, it's not reabsorbed or secreted, so it's perfect, it's ideal. However, it needs to be infused throughout the duration of the test to maintain a constant plasma level. So if we're looking at a 24-hour test, you have to be in a hospital or in a clinic, hooked to an IV for 24 hours, having this infusion done consistently during the time. Not much fun, not a great way of doing it. So we've got this test instead. This is very commonly used. It's the most widely performed procedure evaluating glomerular filtration. It's the creatinine clearance test. So creatinine is a waste product of muscle metabolism that is normally found at a pretty constant level in the blood. It's an endogenous substance that is relatively easy to measure. However, there is some creatinine that is secreted by the renal tubules, resulted in elevated urine excretion. But there's also certain chromogens in the human plasma that react to the chemical analysis, causing a slightly increase in the plasma creatinine. But because of these two factors both happening, they do offset each other. So it is a pretty decent test, because those two factors will offset each other, and we'll actually see what's going on. So we do this test, we determine the number of milliliters of plasma from which the creatinine is completely removed during a 1-minute time period. So this is a 24-hour urine creatinine test. So we do a 24-hour urine collection, and by doing the 24-hour collection, it eliminates any diurnal effect variations in the glomerular filtration rate. We collect a blood specimen in the center, in the middle of the midpoint of the 24-hour urine collection to determine the plasma creatinine value to compare it to the urine. So we know patient compliance with this is not fun. We have to give them the large container. We have to explain to them how to do these tests. They have to collect all urine over 24 hours. They have to keep the urine refrigerated. They have to maintain adequate fluid intake during the process, because we don't want them, we don't want them saying, oh, I don't want to collect all that urine, so I'm not going to drink during the day, so I don't have to pee during the day, so I can still go to work. No, we need them to maintain adequate fluid intake. Avoid any other interferences that might not be normal. We kind of want to catch the normal, so we don't want a lot of extra coffee or tea or heavy exercise. We know, like I said before, the largest problem we're going to have, the largest source of error, is going to be a pre-analytical error for improperly collected 24-hour urine. Patients are not compliant. So once we get this urine in the lab, we're going to use this calculation. Do not memorize this calculation for me. Do not memorize it. You will have it available. But we have to determine the concentration of creatinine in both the plasma and the urine, and then we're going to calculate the creatinine clearance. So C is going to be the clearance. So the C equals the urine creatinine value times the volume of urine in milliliters per minute over the plasma creatinine value. And then we're going to multiply that by the average surface area body, 1.73 per meter squared, over the patient's surface body area. A lot of places, the calculation just takes that last piece out, because we don't necessarily know what the patient's body surface area is. But there is this beautiful nomogram that you can use. You can look it all up, but a lot of places have decided that this does not affect it as much, so they're not going to worry about this as much. So in this situation, you take the height and the weight, you draw a line, and the middle is going to tell you what the surface area of the person is. So here are your reference ranges. Creatinine clearance, 97 to 137 in males, milliliters per minute per surface area. Females, 88 to 128, a little bit less. Plasma creatinine, 0.6 to 1.2 milligrams per deciliter for men. For females, 0.5 to 1.1 milligrams per deciliter. Tubular reabsorption tests, concentration tests, we look for specific gravities. One, depending upon the number and density of particles, it's not ideal. And we all know specific gravity, 1.005 to 1.030, anything in between can be considered normal. But we're looking for consistency and repeatability. Like if somebody is always less concentrated or more concentrated, we're looking for trends over time. Osmolality is better than specific gravity for determining the concentrating ability, defined as the number of osmoles of a solute particles per kilogram of solvent. We determine osmolality based on the colligative properties. So remember, we talked about freezing point, vapor pressure. We talked about all the colligative properties in one of the earlier lectures of a solution affected by the number of particles present. So as the number of solute particles in a solution increases, freezing point decreases, vapor pressure decreases, osmotic pressure increases, boiling point increases. So here's an osmometer. Most labs have gone away from this. Most labs don't have these in the labs anymore, but it's an instrument that'll actually measure osmolality. This is a freezing point osmometer. It is, if the labs still have them, this is the one it's going to use most often. There are also vapor pressure osmometers. We don't see these in the labs very often. There is a fluid deprivation test. I'm just going to talk about this a minute. Do not memorize all these numbers and values. I don't know anybody that's ever gone through this. I don't know people that have done it, but it does exist, and I'm just going to kind of go over some basics here. So we measure urine osmolality after 14 hours of restricted fluid intake. And if we get, this 800 milliosmoles per kilogram of water, it's normal concentrating ability, the test is ended. If the urine osmolality is less than that, they're going to continue the test. So instead of 14 hours in, we're going to do urine and serum specimens at 16 hours. If they can hit normal concentrating ability, they'll stop it here. If they don't meet these conditions, the test is continued. We're going to add antidiuretic hormone, and we're going to test them again at 20 and 24 hours, again, while still being fluid deprived. If they hit a certain amount, kidneys can respond to ADH, but an adequate amount of ADH is being produced. If no response to the ADH, we have abnormal renal concentrating ability. So you see, it's just a test that continues to go on to see, what's going on with the body. Osmolar clearance, free water clearance are another couple options that are out there for other tubular reabsorption tests. PAH clearance test. This is the test most commonly used to evaluate renal blood flow. It's an exogenous substance that is almost exclusively secreted by the proximal convoluted tubules. To perform this test, they infuse the PAH and they look at the amount of clearance. There's titratable acidity and urinary ammonia. Again, very, very rare tests. I'm just kind of throwing them out there so you've heard them. I don't expect you to ever see these again. They're things that are out there.